Chapter 3, we will discuss structure and function of our hematopoietic organs, the organs that make our blood cells. So these are our objectives. We're going to talk about where hematopoiesis occurs throughout a lifespan, a human lifespan. We're going to talk about different organ tissues and primary and secondary lymphoid organ tissues, talk about the function of those tissues, and talk about what happens um, when we have hematopoiesis outside of our normal lymphoid hematopoietic tissue, and then also talk about a couple of other um, disease states as well. So when we are looking at development of our red cells, so or not red, just red cells, any of our blood cells. So the hematopoietic process, it starts as early as the 19th day after fertilization occurs. So it happens very early on. In the beginning, it starts, of course, in the yolk sac. And what happens is there are three different types of cells that are actually produced. So all of our normal adult cells are not produced in utero in the embryo. So in the embryonic development, it's a little different. So we have to have red blood cells, which are erythrocytes, and of course they do transport oxygen. So that actually helps the tissue of the baby or the embryo as it develops. Then we need macrophages, and our macrophages are kind of like our cleanup cells. So they help with antibody production, antigen presenting, but they really kind of help, and they are phagocytic cells. And then megakaryocytes are actually platelets or precursors to platelets. So that helps with clotting, and so that if there's any bleeding, that there are cells available to stop to stop bleeding. So then we start moving after that 19th day up until about 4 weeks. Then we start to get um, more cells being produced than in the yolk sac. And then we actually start getting our hematopoietic stem cells. The hematopoietic stem cells are what will actually go on to branch out and differentiate into all of our adult or normal white blood cells, red blood cells, platelets. And at this point, we are there are some embryonic hemoglobins that are produced. So hemoglobin again is the protein that's inside the red blood cell that helps with the oxygen carrying capacity. So we have hemoglobins Gower 1, Gower 2, and Portland, and these are embryonic hemoglobins that are present after about 4 weeks gestation. And then at that third month, then our liver becomes a primary site of bone cell production. And then after that, you'll start getting more of the adult type of cells with hematopoiesis. So myeloid differentiation, myeloid cells are our white blood cells. And particularly our white blood cells or myelocytes that typically have granules, things like that. Erythroid are our red blood cells. So now we've been seeing a lot of red cells that help. Up until this point, we see a lot of red cells that help with oxygenation of tissues that are developing. Now we're going to start seeing a shift where we are going to now start seeing more white blood cell production. Red cells are still being produced, but now at this stage, at that third month, you're going to start to see more white cells produced. And in the red cells, we moved away from our embryonic hemoglobins, the Gower 1, Gower 2, and Portland, and now we're moving to hemoglobin F. And that is like our fetal hemoglobin, and that's that predominant hemoglobin that will still be there up until birth of the baby. And so as we start to develop beyond that fourth month, then we start seeing our hematopoiesis in the kidneys, liver, spleen, thymus, lymph nodes, our lymphatic systems, helps with maturation of lymphocytes, things like that. And then we start to see that still shift and start moving to the bone marrow. And by the seventh month of gestation, the bone marrow is the primary source. And it continues to be the primary source of where we get our hematopoietic cells to birth and then afterwards. So this just shows you, I'm sorry, this just shows you how the yolk sac and everything, it kind of drops off at the third month. Liver picks up after about 6 weeks or so, between 4 to 6 weeks, and then it spikes out at about 5 to 6 months, and then it comes down at birth. And the bone marrow starts about after the fourth month and actually picks up, and then that's what carries on through life. So that's just a chart showing you from fertilization to birth what where the locations of hematopoiesis are. So when we look at adults, we have hematopoietic tissue in our adults, and it's in tissues that they have there are tissues that actually destroy cells. There are tissues that actually remove cells when they're old, and that is necessary. It's a part of that process of regenerating cells. And as old cells get too old, the body has a mechanism to remove those cells and remove it in a in a safe way that it does not elicit an immune response from or an inflammatory response from your immune system. And then your bone marrow and your thymus and spleen and lymph nodes will make more of those cells. And so the bone marrow, thymus, spleen, and lymph nodes are all some of our adult hematopoietic tissue. So the bone marrow is primarily where we're going to get our myeloid cells. Again, these are white blood cells. We get our erythrocytes. Our those are our red blood cells. Our megakaryocytes, which are our platelet precursor cells, and then early lymphoid cells. So lymphoid cells can mature in one of two areas. And so our lymphoid cells become our things like our lymphocytes. So if it matures in the bone marrow, then it's a B lymphocyte, B for bone marrow. If it's a if it matures through the lymphatic system or through the thymus, T, think thymus, think T lymphocyte. So we have B lymphocytes and T lymphocytes. But for this case, we're just going to say lymphocytic cells. So the thymus, spleen, and lymph nodes, again, help with lymphocytic cell development. And we'll talk about that a little bit more as we talk about the individual cell types. So we have primary and secondary lymphoid tissues. Primary is going to be the bone marrow and the thymus. Already mentioned T cells and B cells. Again, T cells will mature in the thymus. B cells will mature in the bone marrow. One of the things about our lymphoid cells, they can actually respond to foreign antigens. And so, like our B cells can then become plasma cells and make immunoglobulins in response to those antigens. And the immunoglobulins are antibodies. So, they help protect the body against foreign antigens. And then our spleen and our lymph nodes are secondary lymphoid tissues, and they do have some T and B cells. And so it actually help us with our immune response and our memory cells and effector cells. And so once you've been exposed to an antigen, the spleen and lymph nodes of the secondary lymphoid tissues kind of house those cells that remember that for the if you are encounter that again. Again, we'll talk about that in more detail when we talk about the different cells. And then megakaryocytes, as I mentioned before, these are going to be the largest cells that are actually in the bone marrow, and they produce platelets. So all of our other cells, when cells are maturing, through the maturation process, they start out larger and they get smaller. That's typically what happens. So the precursor cells, the blast form, the more immature forms tend to be larger, and as they mature, they get smaller. Well, the megakaryocyte is going to be the largest cell that you typically see in a normal bone marrow. And what happens is it has a lot of cytoplasm and it has a nucleus, but it has a lot of cytoplasm. Well, the platelets are actually the smallest cells that we'll see, blood cells, in the peripheral blood. And so when they're in the bone marrow, they come from the biggest cell, and all they are little pinched off pieces of the cytoplasm as they go into the peripheral blood. So the megakaryocyte is very, very long, very, very large. And we do have to have a certain number of those. We'll talk about bone marrows and things like that a little bit later on in the class and what we expect to see in a normal bone marrow. So our lymphocytes, I'm not going to go a whole like very deep into it. I've already mentioned some of this. Again, your bone marrow will play a part in some of the early maturation of your lymphocytes, and then some of the lymphocytes, precursor cells will leave the bone marrow, go to the thymus, and then that's where they'll fully mature into T lymphocytes. And then there's some that stay in the bone marrow and they mature to B lymphocytes. And I mentioned this before, if the lymphocytes are presented with an antigen and they start making antibodies, these are the B cells that actually become a plasma cell and produce antibody. And we'll talk about that a little bit more a little later in the class. So just some terms that we'll be dealing with. The term hyperplasia means you have too many normal cells. So you have an excess development of normal cells in the bone marrow. So if you have that in the bone marrow, you will typically see it in the peripheral blood. So if we do a CBC or complete blood count, and we'll talk about that on Monday, you will notice the elevated either white blood cell count, red blood cell count, or platelet count, depending on what cell line is increased. So it could affect um, um, any cell line, all cell lines, one cell line, but anything that increases the hematopoietic process or where there's a problem in the hematopoietic process and it's what we call ineffective. So there's something missing or something going wrong in the process. So it's not happening the way that it should. So the degree of it and how bad it is and the severity depends on what's causing the problem. And there are a lot of different things that can cause those problems, and we will actually kind of talk about them in groups throughout the quarter. Some things that can cause hyperplasia, acute blood loss. You have somebody that loses a lot of blood very quickly. So what happens is if you lose blood very short term, like over a long period of time, like with a chronic anemia, so your bone marrow can keep up for a certain amount of time. So it'll kind of ramp up production a little bit. And when it ramps up production, what it does is it actually um, it shortens the amount of time for cells to mature in the bone marrow so that it can push them out a little bit early so that it can kind of help you overcome that blood loss, whether it's chronic anemia, like in a chronic anemia. Well, if it's an acute anemia and you lose a lot of blood all of a sudden, then your bone marrow just kind of goes into hyperdrive and it starts to make a lot of precursor cells to try to get more cells out because ultimately your body is trying to conserve the vital organs. And in doing so, it wants to get more cells out there. And then certain types of leukemia, we can see a bone marrow hypoplasia, and it could be a leukemia where you just have an overproduction, like a multiple myeloma, where you have way too many B cells that are plasma cells. So it's normal to have those cells, but there's just way too many of them. And we'll talk about the different types of leukemias you can see with that. What can happen, you can also have a hypoplasia where now you don't have enough normal hematopoietic cells, and your bone marrow could become inactive. So when we look at a bone marrow, we can actually have fat cells in the bone marrow that's naturally in the bone marrow, and there's a certain percentage we're supposed to have. But what happens is in a hypoplastic state or hyperplasia, you will actually see more fat cells and less hematopoietic cells. It could be usually it's some type of outside environmental factor, like chemicals or toxins. Like if someone is undergoing chemo or radiation treatment, it knocks out it knocks out the cells in the bone marrow. So their bone marrow it appears to be more fat tissue, but it's just really a relative increase in fat because it's really a decrease of all of those that hematopoietic tissue and those cells. So usually it's a result of some type of toxic effect from something in the environment. And there can be some genetic causes. So we will talk about a couple of those this quarter as well. So medullary hematopoiesis, this is what we've been talking about so far. When the hematopoiesis happens in the bone marrow, that's our normal process. Then there's something called extramedullary hematopoiesis. So this is any type of bone cell production that happens outside of the bone marrow. What usually happens in this case with extramedullary hematopoiesis, there is a issue with the bone marrow where the bone marrow cannot keep up, or either the bone marrow is unable to make the cells necessary. And so what happens is, remember during embryonic development and fetal development, the liver and the spleen played a part in the hematopoietic process. Your body reverts back to that. So it's again, it's kind of like a backup of, if the bone marrow is not doing what it needs to do to provide us with the cells we need, your body will flip back to the liver and spleen. That can cause a few other issues, but it's really trying to protect the body. And we'll talk about that a little bit more later as we talk about some disease states when it does revert back. And so the thymus, I've mentioned the thymus, that's where we get our maturation of our T cells. So those precursor cells move from the bone marrow to the thymus and they mature and they become T cells. T cells are very well developed at birth, and then they will the thymus is well developed at birth, not T cells. Thymus is, and it continues to increase inside until you hit puberty, and then the thymus starts to atrophy or get smaller. It continues as you get older. It still you can still produce T cells, but it's not going to be as many T cells. So you have some that are circulating, and then you have some that are kind of in a almost like a storage area in the lymphatic system, and that just kind of gets a little bit lower. So as you get older, it's a little bit harder for T cells to do what they do, simply because you have fewer of them. Your spleen is in the upper left quadrant of your abdomen. You can have your spleen removed, and it's not a problem. So it's not essential for human life, but it is important, um, because one of the things it does is it filters foreign substances. It also removes old red blood cells from circulation. So your red blood cells they live for 120 days when they're old, or sometimes I think the term is called succinct. When they're old, the spleen, when they go through the spleen removes them out of circulation. That also then signals the bone marrow, hey, I'm removing these cells that are 120 days old. The bone marrow should have new red cells to take those place. So it will remove those cells. It also stores platelets, and the spleen does help with immune defense, but your body can survive without a spleen if necessary. So one of the things I just mentioned, that culling is a term where it actually takes out either succinct, which are the old red cells, or if red cells have been damaged, it will remove those damaged cells. And then it also does something called pitting. Pitting is where if there are any particles left inside a red cell, it can remove the red cell without destroying the red cell. So when red cells mature, red cells have a nucleus. As they mature and they get near the mature red cell that we see in our peripheral blood, it spits out the nucleus. But sometimes we have a little things that are left in there, and so the spleen can kind of pinch that out so that the red cell can fully function, and it will close back up. That membrane will close itself back up. Um, so it can produce spherocytes if the pinch is big enough. Instead of the nice biconcave shaped disc of the red cells, it could look like a ball. But those red cells still can carry oxygen, not as well as a normal red cell, but it can still function. So the spleen kind of helps keep you from becoming anemic by just destroying those cells that need something plucked out. So with bloodborne pathogens, bloodborne infections, the spleen has different areas in the spleen. One area, white pulp, very rich in lymphocytes and phagocytic cells. And so as your blood filters through, it can actually help protect and defend your body against some different diseases. Bacteria in particular, Streptococcus pneumoniae and Haemophilus influenza. So this is what we see when children's immune systems aren't as well developed. The spleen kind of helps protect them, particularly against these two infections. And then the red pulp stores some of your like reservoir for your platelets. So all of your platelets aren't circulating. So if you have a bleed, platelets help you stop bleeding. If you have a bleed, instead of trying to push more out of the bone marrow, your spleen can just release more platelets for you. So it's kind of a holding area for that. We can have hypersplenism where the spleen becomes enlarged. It can become enlarged because it's working too much. If it is engulfing a lot of things with phagocytosis and taking a lot of things that out of circulation, like cells out of circulation, it can actually cause the spleen to get enlarged. So you're overworking your spleen. And so when the spleen gets enlarged, it actually heightens everything that it does. So removing red cells, it does that a little bit too well. So it can produce anemia. So also the storage of the platelets, it does that a little too well. So instead of putting them out in circulation, it stores them, and so that causes thrombocytopenia. So thrombocytopenia, thrombocytes are platelets. Leukopenia, same thing. It kind of holds on to those cells. In these cases, and then a combination of cytopenias, it could be just red cell decrease, platelet decrease, or white cell decrease, or a combination of the three. And so what they do in this case is they take your spleen out. That's usually why they take people's spleens out, is because their spleen is hyperactive, essentially. Um, Kind of mentioned some of these. So if they're going to diagnose someone with a hypersplenism, they need to have one of the three cytopenias, and they need to look at your bone marrow. And it's usually a highly cellular, or what we call hyperplastic or hyperplasia in the bone marrow. And so you know you have enough cells in the bone marrow, but you don't see the cells in the peripheral blood. Then that tells you they're getting caught in the spleen. And then they look for enlargement of the spleen. So there can be a primary or secondary. Primary is usually something in the spleen. That's very rare. It's usually a secondary. Secondary is there's something else that's going on and it affects the spleen, and then it causes hypertrophy or hypertrophy of the spleen, meaning more spleen tissue. The spleen gets larger, so the spleen works more. So there are some things that can cause splenomegaly, which is just a term for an enlarged spleen. Hereditary spherocytosis and idiopathic thrombocytopenia, ITP. Hereditary spherocytosis, I mentioned spherocytes a second ago. There is a hereditary genetic condition with the red cells where they're not that biconcave shaped disc shape, they're ball shaped. So the spleen recognizes them as abnormal and it starts pulling all of them out. Well, the problem is it's a hereditary thing and your body keeps producing them. Your bone marrow keeps producing them. So the spleen keeps working, and that increased workload causes the spleen to be have hypertrophy, and then causes the hypersplenism, and then you got to take out the spleen. Um, then there are some other inflammatory and infectious diseases that actually that defensive mechanism in the spleen, it puts that in hyperdrive, causing the spleen to be enlarged. So usually our issues with the hypersplenism is a secondary issue. The primary means there's an issue directly with the spleen. That's usually not our issue. So you can have cells like with Gaucher's disease. These are where macrophages have all this undigested material, and macrophages are where the spleen is where they kind of go to unload, and so the spleen gets engulfed, like gets way too many of these cells in it. You can also have neoplastic cells or malignant cells that take up the spleen volume because again, your spleen is going to try to help your body remove these types of things. Or you can actually have issues where there's blood flow issues, either with cirrhosis of the liver that causes a hypertension, and that increased pressure causes issues with blood flow to the spleen, or you have a patient with congestive heart failure where their heart's not pumping properly to actually push blood flow throughout the body properly. And so you end up having um, blood flow, it doesn't get to the liver, so it gets rerouted through the spleen and it causes hypersplenism. And I've talked about splenectomy and why we can do this. So I've kind of already talked about a lot of this. If you have a hereditary or acquired condition that we can't do anything about, they remove the spleen. And if it's causing the spleen to be hyperactive, we'll remove it. Um, After splenectomy, the lifespan of the red cells, healthy red cells, is still the same. Then the liver will pick up some of the duties of culling or removing cells that the spleen did. It's just not as effective. So it's always your body still has a backup. So even when the spleen's gone, old cells will still be removed. It's just not as effective. So after you have the spleen removed. The cells that actually help and assist with the process of culling are the Kampfner cells. And so in the synoids of the liver, that's where these macrophages are, and then it starts actually pulling those cells out. So the macrophages are phagocytic cells, and they will actually start to like essentially phagocytize those cells that need to come out, and then they can be removed through the liver, through the Kampfner cells. And sometimes we can have what we call, so we talked about splenectomy with removing the spleen. Sometimes we can have what we call autosplenectomy, where essentially there's a disease process going on and it has rendered the spleen ineffective and the spleen can't do its job. So it's essentially like you don't have a spleen, but the spleen's never been removed. And so essentially your spleen's not working because of this disease state, like sickle cell anemia. So when patients have sickle cell anemia, and they have that hemoglobin S, that abnormal hemoglobin, and the red cells move from that biconcave shape, disc shape, to a sickle shape, they can get caught in your vasculature, and that includes in some of the organs. So, and it causes damage to the tissue. So, in patients with have sickle cell and they have a lot of sickle cell crisis, that's usually actually why they die, is because those cells get caught. Those sickle cells get caught in the vasculature of your organs, of their organs, and it destroys the tissues. And so that could happen with a person that has sickle cell, can have an auto splenectomy. And so essentially their spleen cannot function. So that's why they call it acquired hyposplenism. And so if you have any other type of sickling of red cells or things like that, um, it will cause an autosplenectomy due to the tissue damage. And we've mentioned our lymph nodes before. We have lymph nodes all over our body and our lymphatic system. It is a filtrate of the blood plasma and goes through the connective tissues. We'll have, again, our lymph nodes all over our body. If lymph nodes get inflamed, they can get inflamed. When we have disease processes going on, whether they're pathological or not. Pathological meaning something like a cancer or something like that, or lymphoma, or not, it could be you have mono, and that could cause inflammation in your lymphoids, your lymphatic system. And so the lymph nodes have an inner and an outer cortex, but again, your lymph nodes, lymphatic system, um, also help with antigen and making antibodies. So there are some cells that will present the antigen, and then other cells will say that it'll present an antigen, say, hey, we need an antibody to this. And then the B cells are like, okay, I'll make an antibody to this. And so again, they do help with immune defense, and that's another reason why they're all over your body, so they can assist with that. And then we have our mucosal associated lymphoid tissue, or MALT, and they are located through mucosal surfaces in the body, like in the intestines, like the Peyer's patch, the tonsils, the appendix. And so there are some cells that are there that actually help with our immune response, and they can rapidly respond. And it helps to try to trap antigens and keep them from crossing mucosal surfaces. And that's one of our protective mechanisms. So lymphadenopathy is term for enlargement of our lymph nodes, and that's usually due to an expansion of the tissue. It could be inflammation. If you have had if you've had a long response to an infectious agent, so you're infected with something, like you've had mono and you're just not getting over it. And so your lymph nodes can tend to enlarge a little bit because your body is responding to that. It can be due to malignant transformation of your lymphocytes or macrophages, or it could be tumors that come from outside the lymph nodes that then spread to the lymph nodes. So, like patients that have breast cancer, one of the first things that they do when one of the things that they do when they're checking women that have breast cancer, or even men that have breast cancer, they start looking at lymph nodes that are along the center line of your chest and under your arms. They start, especially under the arms, to see if it's spreading that way. So you can have tumors that have metastasized from somewhere else to the lymph nodes.